Okay, जी. Assalamu alaikum. Welcome to this Zoom lectures new series, or we can say the second season 2, and we will wait a few minutes. Because people are still joining, and want to give recording rights to those who have joined. So maybe a few minutes more. Who is this Hawaii? Who is Hawaii? जी अस्सलाम वालेकुम आयदा.
Assalamualaikum, sir. I'm Dr. Aisha Kamal from Pathology Department, sir, from Army Medical College, sir.
अच्छा 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 इतनी दूर से बोल रहे हैं. Clement Law, I've given you the recording rights. Dr. Lubna Falak, you have already got it. And I'm yet to find the friend from Bawalpur. I don't know what happened to them. Okay. I already sent you the program for. ये आप सारे अपने माइक म्यूट कर दें और अगर कोई मैसेज हो तो आप लिख दें उसमें चैट में. डॉक्टर संबल विल मॉनिटर दैट. अगर किसी को रिकॉर्डिंग राइट अभी चाहिए, आई विल गिव जस्ट नाउ लास्ट चांस फॉर गिविंग द रिकॉर्डिंग राइट. अब तो सबके पास है. Okay, ji. In this series, we have started the lectures of, in various topics, and I've already sent you the schedule. Uh, Mostly on Wednesdays, we will talk about this pathophysiology, and on Fridays, on technical aspects, etc., lab management, and we'll divide our lectures between me and Naveed. Uh, but we'll be commonly doing the facilitation, and there is no hard and fast rule that only one facilitator is available. Now, very first thing is that I'm not feeling well today, very bad upper respiratory tract infection, so I may be in low tone today. Yeah. Secondly, in November we have selected some wonderful videos from AACC. You know what is AACC? American Association of Clinical Chemistry. That is the biggest organization of chemical pathologists or clinical chemists in the world. And Alhamdulillah, I'm a member of this AACC for the last many years. Many of our senior chemical pathologists are all our members. And they do a lot wonderful activities, educational activities, and they have given us this model and available on their website. Some I have purchased also. So these are very precious videos, and you will record it in your laptop. And if anybody is interested to get those videos directly from me, then because they are very large files, I can't send it in the by any email. So you have to then arrange some USB, sending USB, or I'll put them in the Dropbox, etc. Such things we can arrange. But the purpose of showing videos along with us is that I'll pause videos, and if I feel that you need some explanation to that, I'll talk to you directly. You can also ask questions or ask me to interrupt in the video and tell me, ask me something which you couldn't understand. Secondly, I will skip some portions, so by doing fast forward. Yesterday, I was trying to trim the videos. We can trim only on the two ends. We cannot trim it in between. So that is, at least I don't know how to trim in between. So best thing is that I will just fast forward those portions which I think it is not needed. Excuse me. Now, today's topic is biomarkers of AKI. This is acute kidney injury is a very common finding, very common occurrence in our critically ill patients. Yeah, and it leads to a lot of morbidity and mortality. And we are still lagging behind in the good biomarkers which can pick this condition as early as possible. So the today's video consists of two uh, speakers. One is a clinician, a nephrologist, who will talk more of clinical things, but he has excellently explained these new biomarkers. The second portion is of a chemical pathologist or a clinical chemist, and she will tell us about the laboratory aspect of those biomarkers. Just an introduction to this what is AKI, and I will not tell you what is AKI because that is part of the video. This slide is very interesting. That this is a comparison between markers of AMI as compared to uh, there is a lot of development of biomarkers of MI or IHD from 60s to 2000s. You see, previously we used to do ASD, CK, LDH, then CPK, myoglobin, then CKMB, and now we totally depend on drops. On the other hand, whereas the mortality, sorry, mortality of uh, MI is 50%, and multiple therapies are available. On the other hand, the AKI has got very high mortality, and only supportive treatment is available. So, need early biomarkers of AKI for improved understanding, early treatment, and better outcomes. This is may not be complete, but some list of biomarkers which have been coming with the passage of time available in the market, and some are available in Pakistan also. For example, cystatin C, we are doing it in our lab. It is though it's a more associated with the low GFR or marker of GFR, but people say that it is also a good marker for AKI. Then microalbumin. This NAG, N-acetyl glucose amidase, in 90s it was very popular, and even in our institute there was some paper on NAG. You must have heard about KIM, kidney injury molecule 1. This was a candidate marker for AKI. NGAL is, you are familiar with NGAL. This NGAL is still quite commonly used in various countries as an early marker of AKI. We are also doing it, and though it is not could not gain any popularity in our clinicians, and very few people advise for this test. There are research projects related to NGAL. We are running them in the lab. Then IL-18, it is not, it couldn't gain in much popularity. Liver fatty acid binding protein, yeah, or liver type fatty acid binding protein. This is another candidate marker. And the latest one are these two, TIM2 and IGF-BP7. These are the latest marker, and mainly today's presentation is about these two markers, TIM2 and IGF-BP7. And I selected this topic because in your exam also you got question, these two questions from recent updates. So this can be a very good question for recent updates. Now we will go to the video. Any newcomers who want sharing? So now we will start the video, and as I told you earlier, the moderator of this small seminar is again a 40% chemical pathologist, and one of the speakers is a nephrologist, and the other is chemical pathologist. The ACC, is an organization which deals with the clinical chemistry or laboratory medicine. So they will give education more related to the laboratory rather than clinical things. Now, these all such activities, they are supported by some pharmaceutical company, and Ortho Clinical Diagnostics is a very famous diagnostic company. Can anybody name the instruments which they make? Vitros. The Vitros series is their product. Okay, now I will start the movie, and I hope I wish it goes well and don't have any technical. But I apologize for any advance apology for any technical hitches and interruptions. Okay.
Email. So Unless there are some housekeeping questions, I think we'll move on to the first of our two speakers. Dr. Kianush Kashani is an assistant professor in medicine at the Mayo Clinic in Rochester, Minnesota, and he serves as a nephrology and critical care consultant. In addition, he's the program director for the Critical Care Fellowship. His research focus is acute kidney injury, including prediction models, electronic surveillance for AKI, and biomarkers of AKI, as well as quality improvement and education. He's published more than 30 peer-reviewed articles, and so please join me in welcoming Dr. Kashani. Where's the yellow? Oh, geez, I thought it was touched me. All right, we're going to let the expert take over.
Dr. Harvey, thank you very much for a kind introduction. Thank you for Congress organizers for the invitation. It is a great honor to be here and participate in this wonderful educational experience. As a matter of disclosure, I received research funds from Astute Medical, which is the company behind development of these two biomarkers that I'm going to present. I have no other conflict of interest for this activity. We will talk about acute kidney injury. Obviously, we go over some epidemiology, the risk factors, impact on mortality, chronic kidney disease, and development of end-stage kidney disease, pathogenesis, and markers of cellular injury. And we focus on pathophysiology of acute kidney injury, how these two new markers are related to development of acute kidney injury. So it is important to understand what acute kidney injury is to begin with. About early 2000s, there were more than 30, 35 different definitions of acute kidney injury. Any researcher wanted to do a study came up with his or her own definition. Therefore, it was very difficult to be able to connect all this data generated by different investigators to come up with a good conclusion. Therefore, a group of investigators they came up with the first consensus definition of acute kidney injury called Rifle criteria. Rifle stands for risk injury failure, loss, and end-stage kidney disease. And the first three stages of Rifle criteria were intensity stages and outcome stages. A few years later, injury network group modified that to would be a stage 3, and they also added absolute rising to stage 1. Now, finally, in 2000.
Okay, let me explain one thing that in probably DLP2 we discussed Rifle criteria, and what he is saying that Rifle criteria is not obsolete, it is not. Instead of that, in 2012, this organization did go. Please mute your. Please mute. Listen to me, please. This kid go. That gave the new staging of the AKI, and it is simply stage 1, stage 2, and stage 3. Very important thing to note is that all these stages, all definition, that depends on creatinine or reduced renal output. Okay, बस सिर्फ ये चीज नोट कर लें कि creatinine based है और reduced urinary output है. ये अब अब इसमें problem क्या है?
Of a lot of definition that we are currently using in clinic and research was born. KDIGO criteria, or kidney disease improving global outcome criteria, are 3 stages based on increasing serum creatinine, both absolute and relative to baseline serum creatinine, and also decreasing urea. It just means that stage 2 is higher intensity than stage 1, and same for stage 3. Whoever receives dialysis is a stage 3 acute kidney injury. I'm going over some epidemiology of acute kidney injury. This study is a little older study, about 20 years ago, looked into 1996 to 2003 national data and the prevalence of acute kidney injury. As you can see, every time period that passes.
Now I'll skip some part because it is not very much related with us.
To avoid further progression and try to avoid mortality, chronic kidney disease, and ESRD. So generally, there are traditional tools that we all use for detection of acute kidney injury. First of all, symptoms. Patients are very variable in their presentation. Some of them have polyuria, some of them have no urine. Some of them could have hematuria or dysuria, different degrees of azotemia, change of mental status. They could have hypertension, hypervolemia, or they could be very hypovolemic and hypotensive. They could have different degrees of acid base and electrolyte imbalances. And also they could have platelet dysfunction, serositis, or other complications of uremia that you are very well aware of. For a very long time, we used urine indexes to be able to differentiate between perirenal azotemia and ATN. And I here in this table examples of those. The issue is that in the systematic analysis was done a few years ago, they looked into the literature to see if there is any literature behind these indexes to prove their efficacy of perirenal azotemia versus ATN in the setting of sepsis and septic shock. There was absolutely no knowledge. And studies were very poorly done, and therefore in ICU setting, on patients who have sepsis, which is majority of patients, we barely can use these particular urine indexes. And in addition, when you have very low urine indexes, which indicates perirenal azotemia, differential diagnosis for those patients are very high. They could have cardiorenal syndrome, they could have contrast exposure, they could have ACE and ARB on board or NSAIDs on board. These are all other causes of low fractional excretion of sodium or elevated urine indexes indicating perirenal azotemia.
You must have noted parameters in teaching. I have been teaching these parameters for quite some time. This fraction excretion of sodium, osmolality, sodium level, fraction urea, osmolality, etc. But he says that the problem is that there is no good study with markers of early detection of AKI. Secondly, he says that these markers are not specific for treatment because many other causes can also finding in these indices.
This table is really hard to read. I just do not want to kind of, you memorize this table. The reason that I put this table is that urine sediment, sensitivity of urine sediments for detection of acute kidney injury is extremely low. It's about 60%. However, specificity of finding is so if you can find some findings in the urine examination, you can be certain that the etiology of acute kidney injury is what the sediment shows. And finally, urine kidney ultrasonography is another tool that we use, although imaging of the kidney has significantly underdeveloped and there are significant room to improve imaging modalities of acute kidney injury. But ultrasonography has been small and shrunk and fibrotic, then we know that the elevated serum creatinine is due to end-stage kidney disease. We start those patients on dialysis and send them home for follow-up dialysis. If the patients have hydronephrosis, then we call urologists to open their pipes. And if the kidney is normal size or enlarged, then differential diagnosis is vast. It would be difficult to differentiate different etiologies based on patients who have normal or slightly enlarged kidney size. Gold standard of acute kidney injury diagnosis is the test that we never do. Were done on children patient population who had no other comorbidities, hadn't underwent cardiovascular surgery. So there was a timed injury and also patient had no other comorbidity. Therefore, these biomarkers performed perfectly. And then authors continue saying results are far less robust when we search for validation in adult heterogenic population, including patients with comorbid conditions such as diabetes mellitus, vascular disease, and chronic kidney disease.
This is a very useful slide, and I thought I must explain to it that when you are doing the in-depth literature search for biomarkers of AKI, the best population to study is pediatric population, because in adults you have got many comorbidities, and the results, there are many confounders, and you cannot find the reliable data. Whereas in pediatric population, the comorbidities are hardly present, and the biomarkers can be assessed very efficiently.
Performance of same markers that were excellent performing biomarkers in the setting of children who underwent cardiovascular surgery when it was tested in sepsis patients in ICU, adult patient population, or even post-cardiac surgery were not even as close to be good. What do we expect from a good marker? We need it to be inexpensive so we can measure it easily. It needs to be accurate. It needs to be as soon as possible. I mentioned that the time acute kidney injury syndrome, we really need to gain time by rapid turnout of the results of these tests. They need to correlate with severity of injury. They need to be sensitive to early subclinical injury. When serum creatinine is not elevated, they should actually show there is injury growing or brewing, recovery, and also response to therapy. This is the current state of biomarkers. There are 3 different domains that we use biomarkers, traditional or novel biomarkers: prognosis, early detection, and differential diagnosis. For differential diagnosis, I mentioned that we use urine indexes to identify between ATN or perirenal azotemia. I also mentioned that this is not very reliable. Obviously, urine microscopy we reviewed, and biopsy. Biopsy is the problem with biopsy is that we don't do it. For early detection, measurement of GFR and serum creatinine are used. Measurement of GFR, all done in a setting of steady kidney function. No test is available to identify patients, measure patients' GFR while they experience rapid moving GFR due to acute kidney injury. And then obviously biopsy help us with early detection. If we're able to biopsy all patients with sepsis who came to the unit, then that would have helped a lot. Okay. Prognosis, so obviously AKI and rifle criteria, as I mentioned, they were validated as prognostication for worse outcome. The higher stage of AKI or KDIGO criteria and rifle criteria were associated with worse outcome. And biopsy urine microscopy also helps. And there are several novel biomarkers that can potentially assist us in development of prognosis and early detection and differential diagnosis. The gray boxes that I had are the two new biomarkers that were published after this paper came out. Whenever you look into interpretation of biomarkers, you really need to consider a 2x2 table of injury versus functional biomarkers. So functional biomarkers of kidney, they show how kidney functions. They do not care what caused bad function of the kidney. Whenever kidney doesn't function, they show a signal. And injury biomarkers show the patients who have injury to the tubular cells. These patients have normal kidney function or poor kidney function. So when the serum creatinine or functional markers go up and biomarkers are negative, so creatinine is normal, biomarkers are normal, there is no acute kidney injury. In comparison, have a sign of injury in their kidney by elevated biomarkers, injury biomarkers, but they have no elevation in serum creatinine or drop in their urine output. They have subclinical acute kidney injury. Indeed, there is growing literature that shows that these particular patient population do worse than those who don't have acute kidney injury at all. And the third group are those who have no sign of injury in their kidney, so biomarkers of injury are negative, but serum creatinine is elevated. We used to call them perirenal acute kidney injury. Those are patients who with a liter or two of IV fluid or improvement in heart function, they recover very quickly. And finally, those who have both elevation in serum creatinine or drop in urine output and injury biomarkers, those are patients who have true acute kidney injury, and those are patients who have higher mortality, CKD, and end-stage kidney disease. Now, all of you are familiar with NGAL or neutrophil gelatinase-associated lipocalin. This is a protein, small protein of 25 kilodalton. It participates in compensating acute kidney injuries, iron chelator increases oxidative stress, also activates other defense mechanisms of the kidney, including hemoxygenase 1. This particular protein is expressed.
Yes, I agree. So that's why I've gone back to this slide. This is a very, very nice slide and very useful slide. That there are two types of biomarkers. One are functional biomarkers. Example is creatinine, cystatin C. The other are structural biomarkers, damage biomarkers, and they are previously albuminuria, and now there are many novel markers also. So by using these two types of markers, you can classify AKI into four groups: no functioning, no AKI, subclinical AKI, renal AKI, and AKI itself. So I think I agree with it. The comment that it was a very useful slide.
Negative, but serum creatinine is elevated. That was the time that we said, well, we have to do something about this because status quo is not acceptable, and we cannot wait for laboratory to tell us what proteins to measure for acute kidney injury. We took a completely different approach. We said, well, we are going to identify patients that are high risk for acute kidney injury, but do not have acute kidney injury just yet. Try to collect blood and urine sample of them in kind of timely fashion, and measure whatever we feel that may be involved in development of acute kidney injury. Indeed, we prepared a list of 340 different proteins that were involved with inflammation, cell-cell interaction, cell cycle. So whatever we could think of that could be related to progression of acute kidney or development of acute kidney injury were measured in these samples. So the three discovery cohorts of Mayo University of Vienna and Duke University, overall more than 500 patients, collected samples and baseline 12 hours later, 24 hours later, and daily for 7 days. So you can imagine how many blood and urine samples we had. We measured all these 340 markers in these samples, and as a result, two of these proteins stood up in detection of acute kidney injury a lot earlier.
Sorry for interruption. This SAPPHIRE study is a landmark study in AKI. And I have an article also. If somebody is interested, I will send you that. This is a very large study, as you see. There were 20 sites from America and 15 from Europe, multicentric study. And it compared many markers with, for AKI. And what they finally selected were these two markers, TIM1 and IGFBP7. And Kashani, this Dr. Kashani is the main author of this study. And interestingly, I have found that sapphire is probably some mineral, some stone, and there are now other studies by these named topaz studies and metal studies, etc. I don't know why they are given this name.
Other proteins. And these two biomarkers that I will introduce were validated in a larger cohort of 35 centers in Europe that enrolled similar patient population, different definitions, a little older age limit of more than 21 year. They had to have some respiratory compromise when they hit ICU to be enrolled. And these patients, about 105 of them developed acute kidney injury. And we measured these two proteins in their baseline sample. When we looked into development of acute kidney injury and compared these two proteins in comparison with other
students, this slide compares the area under curve of various markers. I'm confident that you all know about what is the area under curve in ROC. So we have to study this ROC, and ROC is very useful for us. This slide doesn't show ROC itself. क्या लिखा है sir? There is अच्छा ठीक है. Okay. It's okay. Okay. This slide doesn't show ROC itself. It shows the area under curve in various studies. So how they have done it, that for each marker, they have carried out the diagnostic accuracy study. This is not forest plot, not exactly forest plot. This is actually, Bawalpur, I think other people are listening me well, so you have to do something at your end. Someone else should come and join us in his or her laptop. So the slide shows the area under curve. For example, this top line, this shows 0.8, around 0.8, which is very high area under curve. So what they have done is that for each marker, they have carried out a diagnostic accuracy study or validation study against some gold standard and calculated area under curve for each marker. See our so-called latest markers, which we claim that these are latest markers, cystatin C and GAL. They are performing so poor, even poorer than the creatinine. Urine and GAL is better, but urine IGF-BP7 and urine TIM2, they are at top. And the wonderful thing is that their performance improves tremendously when they combine these two. So in whole of the next presentation, you will see that combination of these two markers, not the combination of these two markers, has got the highest sensitivity and specificity. So the next presentation also is about this. Okay.
Biomarkers, as you can see, the performance was significantly better. So this is area under curve on the x-axis, and these are different biomarkers. So plasma cystatin C, plasma NGAL, serum creatinine, urine NGAL are known biomarkers, and they hang around 0.6 to 0.7. The urine insulin-like growth factor binding protein 7 and urine tissue inhibitor metalloproteinase 2 stood up. In comparison with other biomarkers, their performance was significantly better. And we use a simple product of these two proteins to come up with one single biomarkers. And I'll tell you why we chose to use a product, these two biomarkers. When we divided these cohorts in two different subgroups of sepsis versus surgical, we noted that patients who had sepsis, TIM2 had slightly better performance. And in surgical patients, IGF-BP7 had slightly better performance. So we thought that if we use both of these markers in a panel, simple product, these two measurements, can potentially cover all comers to ICU. We were able to show in a Sapphire trial that there is an
I have to skip this some portion because not very much related to us. So this clinician nephrologist has very nicely explained us that they were fed up of these biomarkers, and he satirically said that we didn't wait for the laboratory persons to guide us, and we took the initiative and we studied ourselves the various biomarkers, and they then carried out this very large study of Sapphire by the name of Sapphire, and they came up with these two biomarkers as the best one. And they think that in future also, he showed in fact a hypothetical patient of 2025 that he's being monitored by these two markers. So that was a sort of an enlightened tone. So now I'll go again to the presentation.
We're going to move on to the second speaker, Dr. Denise Etweiler-Geiger. She's the Director of Laboratory Services and Clinical Trials at John T. Mather Memorial Hospital in Port Jefferson, New York. She's held several technical and management positions, currently oversees new lab technology and lab menu expansion, serves as a principal investigator on several studies, and provides expert professional education, guidance, and consultation to clinicians. She received her Master of Health from the State University of New York at Stony Brook and her doctorate in medical science from the Pacific Western University in Brentwood, California. Include cardiac markers, automation technology, fertility, point of care, patient safety, and clinical outcomes and infectious disease. She's received many awards, including the 2011 Siemens Inspired Healthcare Outcomes Challenge for her work in reducing hospital-acquired infections. She's authored more than 70 peer-reviewed journal articles and book chapters. She's an experienced speaker, and I think we are all looking forward to her perspectives on the laboratory aspects of these new acute kidney injury markers. Dr. Etwaller-Geiger.
Good evening. Thank you, Dr. Horowitz, for that lovely introduction. Thank you, Dr. Kashani, for laying a lot of groundwork for me and setting the stage for what I think is going to be very exciting for you to see these new markers and how we can implement them into the laboratory. So thank you for joining us this evening. Oops. Oh, there it is.
I think we need to do this.
We need to get the red star. It's easier to implement acute kidney injury markers than to start the computer. Thank you. Thank you very much. So the title of the presentation this evening from the laboratorian's view is Laboratory's Role in Acute Kidney Injury Risk Assessment. As part of my disclosure, I do have grant research support from Astute Medical, otherwise there are no other
ethical disclosure.
So during our brief time together this evening, the presentation objectives will be for us to really discuss the value of laboratory information, to describe the laboratory's role in acute kidney injury risk assessment, and I hope that we'll gain on insight into how these new markers can improve clinical while providing high-value patient outcomes. We're also going to examine the clinical research and application of novel biomarkers for the assessment of AKI. So to begin, laboratory information is really our product. And it's said that upwards of 70 to 80% of medical decisions that are made by clinicians originate from the laboratory. And I think this is very exciting to us because there's a lot going on. And if we look at acute kidney injury, it actually gives us the ability to become a liaison to many other clinicians, because who better knows our tests of strengths and weaknesses than a laboratorian? And particularly when we talk about acute kidney injury, this gives us a whole new avenue in which to talk to clinicians about increasing the clinical effectiveness of the laboratory beyond the laboratory's walls. And so in making the case for laboratory diagnostic information, we know that it's an essential element of the healthcare providing system. It's laboratory medicine, it's essential to medical risk and quality management. And we know that laboratory tests and services provide physicians with pivotal information that help us to improve prevention, treatment, diagnosis, and management of disease. We also know that it's pivotal information that allows us to have high quality, safe, effective, and appropriate care for our patients, thereby changing the course of the disease as well as reducing the burden of the disease. If we look at the period from 2005 to 2015, we can see that healthcare spending continues to climb. In 2005, $2 trillion were spent, or almost $6,700 per person. If we look at projected values of cost for 2015, it's at $3.3 $1.2 trillion, or $10,000 per person. And this is in spite of Obamacare. But did you know that the laboratory is only 3% of that total healthcare cost spend? And I think that the contributions of laboratory services to the integrated healthcare delivery system, as well as an important component of that piece of information that we're able to give, is totally under-recognized. And it really is. It is incumbent upon us as laboratorians to prove our value and show that the laboratory can be an excellent partner in bringing value to our patients. And I think that we're beginning that journey with looking at acute kidney injury markers. Well, to understand how we can solve our problem, we really need to recognize that there is a problem. And I think we need to really examine the scope of that problem. When it comes to acute kidney injury, there are many statistics that are associated with that. We know that 1.2 million people a year get AKI during their hospital stay, or 3.5% of those admissions. We know that it increases length of stay by 3.5 days. We also know that there's a higher mortality rate associated with that. And perhaps what you didn't realize is that acute kidney injury has more deaths associated with it than breast cancer, prostate cancer, heart failure, and diabetes, all combined. That was.
Have you noticed this information that deaths due to AKI are greater than the deaths due to cancer, diabetes, mellitus, heart disease combined? So it's a very, very important condition, because in critically ill patients, patient suffer AKI, and then they are put on dialysis, and sometimes they do not recover from dialysis, or they go into CKD, chronic kidney disease. This is very important.
An aha moment for me when I realized, because in the laboratory, I think when we look at the tests that we have available today, creatinine and perhaps looking at BUN in some instances, is that
ये बड़ा interesting sentence है,
as well as an important component of that piece of information that we're able to give, is totally under-recognized. And it really is incumbent upon us as laboratorians to prove our value and show that the laboratory can be an excellent partner in bringing value to our patients. And I think that we're beginning that journey with looking at acute kidney injury markers. Well, to understand how we can solve our problem, we really need to recognize that there is a problem. And I think we need to really examine the scope of that problem. When it comes to acute kidney injury, there are many statistics that are associated with that. We know that 1.2 million people a year get AKI during their hospital stay, or 3.5% of those admissions. We know that it increases length of stay by 3.5 days. We also know that there's a higher mortality rate associated with that. Perhaps what you didn't realize is that acute kidney injury has more deaths associated with it than breast cancer, prostate cancer, heart failure, and diabetes, all combined. That was quite an aha moment for me when I realized, because in the laboratory, I think when we look at the tests that we have available today, creatinine and perhaps looking at BUN in some instances, is that we have so little information that we don't really have AKI on our radar screen until we hear people like Dr. Kashani explain that to us and how the impact is clinically to our patients. We also know that 300,000 people die annually from AKI. And perhaps, interestingly enough, is that it has a staggering healthcare cost associated with it, $9 billion a year. And that leads to about $7,500 per patient of excess hospital costs. So it's very big a healthcare burden. Well, I think you can see that from the statistics I've shown you that there are many challenges. And one of the challenges that we have is that up until now, we really have had unmet clinical needs when it comes to assessing the risk of AKI. Basically, we've not had tests that have been rapid, sensitive, or specific. And those are the kinds of tests that we need so that we're able to identify, treat, and better manage these patients. because ultimately what we want to prevent is having irreversible kidney damage. So if we can identify the event with risk assessment before it happens, then we can do treatments that would be kidney sparing. And therefore, if we can recognize AKI with rapid onset, with response to acute injury, we can make those changes. And so for the laboratorian, what would that ideal marker look like for AKI? Well, we want it to be specific for AKI, and that it needs to be sensitive enough for the detection of clinically significant AKI. We'd like it to be capable of estimating the extent of the damage, and we know it needs to have rapid kinetics so that we have rapid acute changes that we can measure. It would be nice if it had a prognostic component to it where we could look for short and long-term outcomes of our patients. And as laboratorians, we're always interested in the analytical performance because it needs to be very solid and robust. We'd also like it to be a fast turnaround time, easy to measure, and cost-effective. And that really speaks to perhaps 4 tenets that are very important today as we transition for a fee-for-service system to more of a value purchase system. We need to.
ये एक लफ्ज आजकल बहुत लिटरेचर पे आ रहा है, एंड वो वर्ड है वैल्यू. वैल्यू जो मीन्स whenever whatever you are doing in the lab or in clinics, in hospital, you are doing a test, you are giving a medicine, you are doing a procedure, you are doing a surgery. What is its value? Value means how much this particular thing is reducing the cost. Is it cost effective? Is it patient friendly? Is it reducing the hospital stays? Is it reducing the readmissions? So now everything is assessed, and the term uses value. So this value means
cost effectiveness.
Cost, not only cost, patient stay, patient comfort, patient safety, all things combined. So this is, I probably in the workshop also told you that these are called outcome studies. Outcome. What is the outcome of this? So whenever you hear this word value, it is not the simple English word value. It means larger meaning.
It's the outcome of this.
Outcome of this study means of that particular thing. Study नहीं sir. Study तो आप करेंगे ना. आप value का मतलब ये है कि जो आप कर रहे हैं उसका क्या फायदा हो रहा है. फायदा क्या हो रहा है. बस ये समझ लें आप. आपने अगर पैसे खर्च रहे हैं, अगर महंगा टेस्ट भी कर रही है, आखिर में जाके बड़ा अच्छा कॉस्ट बताएगी आपको. अगर महंगा भी है लेकिन अगर उसकी वैल्यू ज्यादा है तो यस यू कैन यूज इट. लेकिन अगर एक सस्ता कर रहे हैं उसकी कोई वैल्यू नहीं है तो यू शुड स्टॉप इट. ठीक है.
Fast turnaround time, quicker diagnosis, and we also need to be able to show cost savings or cost avoidance, and we also want to be sure that we improve patient satisfaction as well as clinician satisfaction. And so the 2 markers that Dr. Kashani introduced to you were the tissue inhibitor of the melanoproteases, number 2 or TIM2, as well as the insulin-like growth factor binding protein 7 or IGFBP7. And just to recap, TIM2 is a protein that is an inhibitor of the matrix melanoproteases. It is one of 12 of those melanoproteases. It directly suppresses the proliferation of those endothelial cells, and it inhibits the protease activity in tissues that are undergoing that remodeling of the extracellular matrix. It is also implicated, as you heard, in epithelial cell cycle arrest. Insulin-like growth factor binding protein 7 has involvement in the regulation of the tissue's availability. It also stimulates cell adhesion by prostacyclin production, and it's also implicated in the epithelial cell cycle arrest. So what do these 2 markers have in common? Well, they're both inducers of G1 cell cycle arrest, which is a protective mechanism. And so that is what is at the very core of, we believe, to be the mechanism that makes these 2 markers better than other markers, and is very early in the event. Until now, the discovery and validation pathway for the typical new biomarkers have been through human clinical studies and animal model studies, which really have allowed us to gain a better understanding of the pathophysiology of complex disease. But when we look today at emerging proteomics, we now have the ability to look at proteins, as was done with the discovery trial, that actually identified over 340 biomarkers. And from those biomarkers that were discovered through that proteomic discovery, a select set of those markers were looked at. Two of those markers, the TIM2 and the then had a development for a test that created and validated that assay onto a test platform. And that test actually takes the two markers, multiplies them, combines them to
a mic off करना please, mic off करें.
AKI risk score.
ये बड़ी इंटरेस्टिंग स्लाइड है. ये बताती है कि कैसे रिसर्च होती है. सबसे पहले देखिए उन्होंने कैंडिडेट बायोमार्कर आइडेंटिफाइड किए और 340 मार्कर्स थे. 340 हमें नाम भी नहीं आ सकते. और वो डिस्कवरी स्टडी थी जिन्होंने 340 कैंडिडेट मार्कर्स ढूंढे. फिर सारे मार्कर्स को वैलिडेट किया गया. वैलिडेट का मतलब उसकी डायग्नोस्टिक एक्यूरेसी वगैरह निकाली. ठीक है. उसमें फिर मुख्तलिफ स्टडीज हैं. जो सेफायर स्टडी है, सेफायर स्टडी ने जब सारों की वैलिडेशन की तो अल्टीमेटली they come to the conclusion that combination of these two biomarkers is the best one. ठीक है. तो ये जो अब इनका कॉम्बिनेशन ही अवेलेबल है, जो कमर्शियली वहाँ पे अवेलेबल है और FDA अप्रूवल भी आ गई है इसकी, अभी बताएगी. वो ये नेफ्रोचेक के नाम से है. वो इसका एक स्कोर दोनों का मल्टीप्लाई करके एक स्कोर करते हैं. क्या आइडेंटिफाई? अच्छा ठीक है, अभी देखते हैं बेटा. ये जो रिकॉर्डिंग राइट्स है ना, ये अर्ली बर्ड्स को मिलेंगे. बीच में इंटरप्ट करना बड़ा मुश्किल है. ठीक है. तो ये जो है मैं बता रहा था कि जो दोनों का कॉम्बिनेशन होता है नेफ्रोचेक के नाम से, एक ये रिस्क और इसका स्कोर निकलता है. फिर आप आगे जाके देखेंगे कि इसका स्कोर आपको अवेलेबल होगा. तो ये एक कॉम्बिनेशन है दोनों का.
And so those two markers in one cartoon, one answer with an AKI score was validated in the SAPPHI clinical study. So let's take a look at the clinical study. The SAPPHIRE study demonstrated that TIM2 and IGF-BP7 outperformed the existing biomarkers. And you can see here, as Dr. Kashani had actually shown this one, is that when you compare the area under the curve for a number of existing markers for AKI, both urinary markers and plasma markers, you can see that the standouts with the greatest amount of area under the curve at 0.80 is the combination of TIM2 and IGF-BP7 together, TIM2 and IGF-BP7. The next closest marker to that, with the area under the curve at about 0.7, is urine NGAL, and the others are much further behind. So you can see that the area under the curve for the combination, which actually then translate to the AKI risk score, was significantly greater and outperformed the existing biomarkers, whether they were plasma or urine. We also know that TIM2 and IGF-BP7 have a very compelling specificity profile. And shown here on the slide, comparing the profile for specificity, on the right is the TIM2 and the IGF-BP7, while on the left we're comparing urine KIM1. And if we look urine urine KIM1 in the blue color
next
here,
two slides, because now she's telling us the specificity of these two markers. So दो स्लाइडें हैं, एक में यूरिन केम 1 से कंपेयर किया, दूसरे में एक और मार्कर से किया. तो इसमें अब समझने वाली, क्योंकि ये कॉम्प्लिकेटेड है, मैंने सोचा कि आपको खुद मैं बता दूं कि ये जो केम है, किडनी इंजरी मॉलिक्यूल 1, इसमें जब उन्होंने एनालिसिस किया तो AKI में तो और वेरियस स्टेजेस ऑफ AKI में ये रेज था, लेकिन इसके साथ साथ बहुत सारी दूसरी कंडीशन में भी रेज था केम 1. सो दैट मींस इट्स स्पेसिफिसिटी इज पुअर. because it when it is positive, it is rare. There can be other causes also. On the other hand, these two when these two marker combination, it was study. You see the levels of these two markers were very low in other conditions and very high in various stages of this AKI. In stage 1, it is less, then higher in stage 2, and further higher in stage 3. So you see, it is wonderful results. Similar slide is next, and she's explaining the same with urine gall. Again, in urine gall, the urine gall is higher in AKI, but also higher in other conditions. And whereas these two markers are not higher. Okay, so we will skip this slide also, which is almost the same. Then they have studied it with this in sepsis and surgery, and again the results are in front of you. And we can again dispense with this slide. In apparently healthy donors or no AKI, the results are low. Okay, now we go to this slide.
As a single test. It should have the capability to assess for the risk of AKI within the next 12 hours so that we can stop irreversible damage. And that in order for it to be clinically significant, it needed to be provided in less than 20 minutes. And as laboratorians, we'd like to see CVs that were at least less than or equal to 15%. And this test did clear the FDA this past September. And I'll read to you what the clinical intended use was, because this is the on-label definition as defined by the clearance through the FDA process in the de novo process. And it said basically that the clinical system or the NephroCheck test is a in vitro diagnostic device that quantitatively measures TIM2 and IGFBP7 proteins that are associated with kidney function in human urine by fluorescent immunoassay on the astute 140 meter.
So the technique is fluorescence immunoassay, and this astute 1400. This is an instrument. And this immunoassay is done on this instrument, and probably it is one of the products of this orthoclinical diagnostic. In the slides, she will also tell us that this test is also available on vitros.
This is a moderate complexity test, and it is intended to be done in the central laboratory. The test is intended to be used in conjunction with clinical evaluation in patients who currently have or have had within the past 24 hours acute cardiovascular and or respiratory compromise, and are ICU patients as an aid in the risk assessment for moderate or severe acute kidney injury within 12 hours of that patient assessment. And this test is intended to be used in patients 21 years of age or older.
अब ये इसमें बताया है कि जो FDA है, जो उनका बहुत बड़ा इदारा है, जो हर ड्रग को अप्रूव करता है, FDA अप्रूवल के बगैर कोई ड्रग नहीं यूज हो सकती, उसका नाम ही फेडरल ड्रग एजेंसी है, लेकिन टेस्टों की अप्रूवल भी वो FDA देता है और इवन इंस्ट्रूमेंट्स की अप्रूवल भी देता है. तो आप ये आपके लिए थोड़ा सा इम्पोर्टेंट है नॉलेज कि जब आप किसी इंस्ट्रूमेंट को या टेस्ट को परचेज करने जाएं, शुरू करने जाएं, तो आपके पास कोई इंटरनेशनल अप्रूवल होनी चाहिए. And biggest of those is FDA, and then there is also European approval and Japanese approval. You can have those two. In government sectors, we can only employ those instruments or those tests or those drugs which are approved either of these these two, European and FDA approval. Now, what FDA has approved, that this test, the combination of these tests by the name of NephroCheck, can be used as an added supportive test for the early diagnosis of AKI in ICU patient. ये नहीं कि आप OPD patient में करें इसको. No, जो इसकी approval है उसमें specify किया गया कि आप इसको ICU patient में करेंगे और कब करेंगे, within the past 24 hours जिनको कोई event हुआ है, ठीक है. और ये क्या करेगी, बताएगी कि नेक्स्ट 12 आवर में इसको AKI हो सकता है पेशेंट को. ये नहीं कि हुआ है, नेक्स्ट 12 आवर में इसको AKI हो सकता है, ये इसकी है। लेकिन अगेन ये सपोर्टिव है, आप बाकी चीजें भी उसमें साथ करेंगे, ये FDA ने कहा है। और बच्चों में यूज नहीं करना इसको, ये भी कहा है, इट शुड बी यूज्ड ओनली इन पेशेंट अबव 21 इयर्स ऑफ एज। तो FDA जब अप्रूव करता है तो साथ कंडीशंस भी लगाता है, तो फिर इनकी मार्केटिंग बहुत आसान हो जाती है जब ये FDA अप्रूवल हो जाती है।
So shown here is the test process, the actual flow of performing the test. It can be performed on either fresh or frozen urine that's been thawed. It does use a single cartridge with lateral flow sandwich immunoassay. Results are available in less than 25 minutes, including hands-on processing time. It is a tabletop meter. And I think most importantly for you to understand is that this is reported as a single numerical number, the AKI score, and it's reported in nanograms per ml, which is divided by 1,000. So the combination of those two markers is multiplied and provides one single quantitative test.
Okay, अब आपको समझ आई कि इसको आप
And so I'm looking at some of those performance.
ये देखिए, इसकी रिपोर्टिंग कैसे करनी है आपने, ये बता रहे हैं कि ये इसको आप जब रिपोर्ट करते हैं तो आप इंडिविजुअल टेस्ट की रिपोर्ट नहीं निकालते, आप दोनों को मल्टीप्लाई करते हैं, दोनों नैनोग्राम पर ml में आप मल्टीप्लाई करते हैं उसको और 1000 से डिवाइड करते हैं। तो उससे जब आपकी लेबोरेटरी रिपोर्ट इसकी निकालेगी तो वो उसको स्कोर के तौर पर निकालेगी। और अब बोलते स्कोर की कोई यूनिट नहीं होती, जो स्कोर होता है उसकी कोई यूनिट, इंडेक्स है ये, हाँ कोई यूनिट नहीं होती उसकी, बिकॉज वो नैनोग्राम्स को उन्होंने 1000 से डिवाइड किया हुआ है, पहले दोनों को आपस में मल्टीप्लाई किया और फिर 1000 से डिवाइड किया। तो अगर आप नेफ्रोचेक पे करेंगे और ये डिवाइस है इसका एस्ट्यूट के नाम से, छोटा सा ये इंस्ट्रूमेंट होगा, और देन विच टेस्ट फॉर चिल्ड्रन एज इज द आइडियल एज ग्रुप 2 स्टडी फॉर द AKI। हाँ ये सही क्वेश्चन है आपका आयशा, ये देखें चिल्ड्रन के लिए होगा, जरूर होगा ये, जैसे आइडियल पॉपुलेशन है, लेकिन प्रॉब्लम ये है कि FDA ने नहीं अभी प्रूव किया फॉर चिल्ड्रन, FDA ने इसको सिर्फ अभी एडल्ट्स के लिए प्रूव किया। तो मे बी अभी स्टडीज हो रही हो, बाद में ये चिल्ड्रन के लिए भी आ जाए तो, लेकिन अभी इन्होंने बच्चों में असल में बाकी भी इतने बुरे नहीं परफॉर्म करते, बाकी टेस्ट जो होते हैं ना, कोमॉर्बिडिटीज नहीं होती ना बच्चों में, ये मैं बता रहा हूँ। इवन एनगाल भी ठीक कर लेगा परफॉर्म, ऑल मार्कर्स भी ठीक परफॉर्म कर लेंगे, तो लेकिन और ये भी हो सकता है इनकी भी परफॉर्मेंस बहुत अच्छी हो, लेकिन अभी FDA अप्रूवल नहीं आई फॉर चिल्ड्रन, ये इंपॉर्टेंट बात है। ठीक है, अब ये आपको जानना क्यों जरूरी है, कल को आके आपके कोई फार्मा वाला या डायग्नोस्टिक फॉर्म वाला कहता है जी हमारी FDA अप्रूवल है, उन्हें कहीं ला के दिखाओ, वो उसमें कंडीशन लिखी होगी कि ये टेस्ट फला डिजीज के लिए, फला एज के लिए सिर्फ वो है। ठीक है, तो ये उनकी बातों में नहीं यकीन करना। ठीक है, वो झूठ नहीं बोल रहा है, FDA अप्रूवल है, लेकिन किस चीज के लिए है भाई। ठीक है, ये इससे लेसन मिलता है हमें।
Numerical number, the AKI score, and it's reported in nanograms per ml, which then are divided by 1,000. So the combination of those two markers is multiplied and provides one single quantitative test result. And so in looking at some of those performance characteristics here, the high sensitivity of the clinical cutoff for AKI at a score that's greater than 0.3 really identifies the majority of patients who are at risk for AKI while providing or maintaining acceptable specificity for these markers. And you can see here that moving from left to right, we have the apparently healthy subjects, followed by those subjects that have stable chronic morbidities, but they are critically ill patients. And then we have the next column, which is our patients that have no AKI. And then we compare those numbers to the numbers of patients that we saw in study A and study B. And in these two studies, we had the ability to look and differentiate the severity of AKI based upon moderate to severe AKI. And you can see here that at a cutoff, shown in the blue line here, the arrow, is that right there shows that differentiation between that cutoff of 0.3 and those patients that had elevations in AKI. And these patients actually had a sensitivity of 92% in the study A and 76% in study B. And for those patients that had AKI cutoff of 0.3, those patients that were less than that had a 92 to 95% chance of not having AKI. In contrast, those patients that had a value above the 0.3 cutoff actually had a 1 in 2 chance of being AKI positive. So what this does for us really is it allows us to have a very those patients with 98% chance of not having AKI, and allowing us to turn our attention to those patients that are above the cutoff of 0.3, where there can be more intervention and monitoring of these patients for kidney-sparing therapies and management. If we look at the reportable range and the reference range, the reportable range for the AKI score is 0.04 up to 10. And so if you have a value that's greater than 10, there is not a recommendation to do a dilution, but to report that result as a greater than 10, and at the lower end of 0.04, it would be a less than result that would be below the cutoff for the report range. And shown on the bottom here is the cohort that was shown in the previous slide with the apparently healthy subjects, the chronic morbidities, as well as the intended use who had no AKI, as well as the patients who did exhibit AKI. And you can see here that looking at the range for those patients, all the way up to 8, as low as the 0.4 for patients that were apparently healthy. The analytical sensitivity for the assay for AKI risk score has been determined by looking at the limit of blank, the limit of detection, as well as the limit of quantitation. This was done by following the recommendations in the CLSI guideline.
Okay. जो अभी सिट के लोग आए थे उनको हमने बड़ा अच्छा बताया था मेथड वैलिडेशन में कि व्हाट इज एनालिटिकल सेंसिटिविटी. एनालिटिकल सेंसिटिविटी is the can be defined as the change in the response in relation to the change in the concentration, but it is generally applied to the detection of the lowest value. तो ये जो स्लाइड है ये वो बता रही है कि लोएस्ट वैल्यू आप इसकी कहाँ तक आप डिटेक्ट कर सकते हैं. लिमिट ऑफ ब्लैंक जो होता है वो उसका मकसद ये होता है कि आप किसको ब्लैंक कहेंगे, कौन सी चीज है जिसको आप ब्लैंक कहेंगे. तो वो ब्लैंक कहने के लिए जो उसका है वैल्यू वो 0.0002 है. और लिमिट ऑफ डिटेक्शन वो होती है, क्या होती है सिंबल? हाँ यानी आप उसका सिग्नल जो है ना वो ग्रेटर होता है, उससे सिग्निफिकेंटली ग्रेटर होता है एज कंपेयर टू द सिग्नल नॉइज रेशियो है वो 3 से ज्यादा होती है. दैट इज लिमिट ऑफ डिटेक्शन 3 से ज्यादा होती है एज कंपेयर टू ब्लैंक. और लिमिट ऑफ क्वांटिफिकेशन वो होती है जिसको आप एक्चुअली बड़ी कॉन्फिडेंटली कह सकते हैं कि ये एक्यूरेट एंड प्रिसाइज है. और इसके जो मेथड है वो ये कि शुड बी सिग्नल नॉइज रेशियो शुड बी greater than 10 as compared to blank. और ये नीचे जो कहानी लिखी हुई है ये भी बड़ी जरूरी है आपके लिए कि इन्होंने एनालिटिकल सेंसिटिविटी निकालने के लिए कौन सा मेथड फॉलो किया है. तो ये CLSI एक इनका है, क्लिनिकल लेबोरेटरी स्टैंडर्ड इंस्टीट्यूट, वो उसकी EPI गाइडलाइंस है, प्रोटोकॉल है फॉर डिटर्मिनेशन ऑफ LOD एंड LOQ, उसको फॉलो करके उन्होंने निकाल लिया. वैसे ये नहीं होता कि अपने तौर पे आप निकाल दें, ठीक है. तो CLSI ने जो गाइडलाइन दी हुई है उससे उन्होंने निकाला है. हमारा जो फ्राइडे को सेशन है आप जरूर करें, आप बहुत इंजॉय करेंगे. वो सारा क्वालिटी मैनेजमेंट पे और इस पे है, मेथड वैलिडेशन वगैरह पे, ठीक है. और वो जो स्पीकर है वो आप सब उसको जानते हैं, बहुत अच्छी तरह जानते हैं. स्पीकर का नाम है वेस्टगार्ड. तो जेम्स वेस्टगार्ड और उसका बेटा है दूसरा वेस्टगार्ड जूनियर, वो दोनों की प्रेजेंटेशन है. और वो सुनने के लिए तो लोग दुबई जाते हैं खास तौर पे, तो मैं आपको घर बैठे सुना दूंगा, ठीक है. चलेंगे नेक्स्ट
17-8, and you can see here that all of the values for the limit of detection, blank and quantitation are all very low, and they're significantly below the apparently healthy donors, so that we're able to measure with adequate sensitivity these two markers in samples, and that it has acceptability for clinical use. If we look at the precision, this precision table shows the precision that was done using 3 lots of the NephroCheck test kits that were measured at 3 testing sites under the intended clinical use. And these samples are 6 samples that actually span the clinically relevant range for these samples, from sample 2 being at the cutoff of 0.04 or the bottom of the range for the apparently healthies, all the way up to S7, which is at 8.55, and perhaps most importantly, at sample S4 at the cutoff of 0.3. And you can see that there's acceptable CVs for all of these samples that span the clinical concentration range. And at
अब ये जो precision study है, ये हमने आपको बताया हुआ है, replication study है, precision study करते हैं, तो इन्होंने ज़ाहिर कंट्रोल लिया है या सैंपल लिए हैं। जो नोट करने वाली बात है कि सिर्फ एक लेवल पे नहीं किया, हम आमतौर पे एक लेवल पे करते हैं। अगर आपने अच्छी प्रिसीजन स्टडी करनी है तो आप पूरी रेंज पे करें। ये जो सैंपल 2 है, ये 0.04 था, 0.04 को उन्होंने मल्टीपल टाइम 20 या 30 टाइम रन किया, ठीक है। और 2 नहीं, वो लिखा हुआ है 2 टेस्ट पर डे फॉर 20 डेज, ठीक है। ये प्रोटोकॉल फॉलो किया उन्होंने। और S3.14 था सैंपल, उसकी एक्चुअल वैल्यू। और S4 सबसे इंपॉर्टेंट है। क्यों इंपॉर्टेंट है? ये कट ऑफ है, ये कट ऑफ। तो इस पे जो है ना, इसका स्कोर बहुत अच्छा होना चाहिए, क्योंकि ये तो डिसीजन लिमिट है। तो वो भी 10 पॉइंट। और इसने शुरू में बताया था कि 15% CV इज एक्सेप्टेबल। तो S2 नहीं क्वालिफाई कर रहा है। S2 में ये इसकी CV बहुत हाई है, 15 से ज्यादा है, लेकिन बाकी सब में एक्सेप्टेबल है। तो इससे हमारी साथ साथ की ये जो प्रेजेंटेशन है, चूंकि लेबोरेटरी वाली की है, तो इसमें हमें ये चीजें भी सीखनी है कि कैसे परफॉर्मेंस एनालिसिस वगैरह की जाती है। आगे जाके और डिटेल में बताएगी कैसे परफॉर्मेंस चेक की जाती है। तो ये प्रिसीजन स्टडी थी। और ये कौन सी प्रिसीजन है? ये विद इन बैच है, इंटर बैच है, विद इन डे है, इंटर डे है, ये रिप्रोड्यूसिबिलिटी है, रेप्लिकेबिलिटी है, क्या है ये? बिटवीन डे। तो ये तो उन तीनों में से कौन सी, किस टाइप की प्रिसीजन है? इज इट रेप्लिकेशन स्टडी, रिप्रोडक्शन स्टडी, रिप्रोड्यूसिबिलिटी स्टडी, रेप्लिकेबिलिटी स्टडी, और तीसरी कौन सी होती है? इंटरमीडिएट प्रिसीजन स्टडी। कौन सी है ये? नहीं, इंटरमीडिएट प्रिसीजन। इट इज इंटरमीडिएट प्रिसीजन स्टडी, ठीक है। लेकिन ये वैसे डिफरेंट साइट्स पे हुई है, तो आप उसको रिप्रोड्यूसिबिलिटी कह सकते हैं, लेकिन अब हम क्लासिकली इसको इंटरमीडिएट कहेंगे, उससे उन्होंने एक ही मेथड यूज किया सब जगह पे, ठीक है।
0.30. The total imprecision is at 10.4%, which is certainly acceptable, and the highest is at the low end at 18%. And now this is total imprecision because these are samples that were tested for 20 days, 2 runs per day, 2 replicates per run, across 3 sites with different operators within run and run to run. So it was a very robust precision study, and certainly does show acceptable precision. And one of the things that I'd like to show you tonight, and this is actually breaking news at the meeting, is that there is a poster here that for the first time shows a method comparison using the VITROS 3600, and comparing this back now to what would be the predicate device, the Astute Meter 140. So for the first time, we have a predicate device, and we have a method comparison. And what you can see here is that with the development of an assay that uses these 2 markers on a high throughput automated analyzer, we had very excellent overall agreement at 92%, with the positive agreement is at 88%, and its negative percent agreement is at 98%. And the R is at 0.92. So for the first time, comparing the Astute meter to a high throughput
इसमें मुझे थोड़ी सी ऑब्जेक्शन है वैसे। ये कह रही है कि हमने एस्ट्यूट 140 को स्टडी किया, एक्चुअली तो उस इन्होंने विट्रोस को किया एक्चुअली। ये वो बता रही है कि विट्रोस जो ऑटो एनालाइजर है उस पर भी अवेलेबल है ये टेस्ट इसी नाम से, तो वो चूंकि मेरा ख्याल है कंपनी एक ही है, लेकिन चूंकि इसने वाई एक्सिस पे विट्रोस रखा है तो एक्चुअली तो ये टेस्ट जो एनालिसिस हो रहे हैं विट्रोस का हो रहा है ना, पता नहीं, मुझे तो ये लग रहा है। तो क्या ये रही है कि एस्ट्यूट कौन ने किया, जो इनका दूसरा मेथड है। बहरहाल इसमें दो चीजें हैं, एक तो आर की वैल्यू दी है, जो जो कोरिलेशन स्टडीज होती है पियर्सन कोरिलेशन, ये आर वैल्यू दी है ये वाली, और वो 0.92 है। वैसे हम तो कहते हैं 0.97 से ज्यादा होनी चाहिए, 12 उन्होंने 0.92 को एक्सेप्ट किया है। और उसके बाद ये कौन सी चीज ड्रॉ की हुई है, ये कौन सा स्टैटिस्टिकल मेथड यूज हुआ है, लीनियर रिग्रेशन, ठीक है, लिखा भी हुआ है उसमें, ये लीनियर रिग्रेशन से किया हुआ है। और इसमें ये 3 इन्होंने दिया है कि ओवरऑल यानी दोनों टेस्टों की एग्रीमेंट, असल में तो एग्रीमेंट देखने के लिए होता है ना। मैंने ये जो के स्टूडेंट्स आते हैं इनको मैंने बताया था बड़ा अच्छा कि ये जो लीनियर रिग्रेशन है, दिस वेरी गुड मेथड टू सी द इन डेप्थ, जो हिडन इनर एरर है उसको ढूंढने के लिए ये सबसे बहुत अच्छा मेथड है। एक दूसरा मेथड भी होता है, उसका नाम क्या है, ब्लैंड ऑल्टमैन प्लॉट। तो ब्लैंड ऑल्टमैन प्लॉट, लीनियर रिग्रेशन, ये एग्रीमेंट स्टडीज हैं कि दोनों की कितनी एग्रीमेंट है। तो राइट, ये जो टेबल नीचे दिया है इसमें ओवरऑल एग्रीमेंट है, और जब टेस्ट पॉजिटिव है फिर कितनी एग्रीमेंट है, और जब टेस्ट नेगेटिव आए तो फिर कितनी एग्रीमेंट है, यानी 0.3 से कम हो या 0.3 से ज्यादा हो। अब वो एक्स की वैल्यू पे आप डिफरेंट कट ऑफ लगा के तो आप उससे निकालते हैं, ठीक है। तो मेथड तो वही होगा, नहीं विट्रॉस में मेरा ख्याल है एम्यूलेसेंस होगा। विट्रॉस आई डोंट नो फ्लोरेसेंस पे कोई विट्रॉस है या नहीं, क्योंकि इसको एक्सप्लेन नहीं किया उसने। हाँ जी, लेकिन ये एस्ट्यूट तो फ्लोरेसेंस है, हाँ वो तो फ्लोरेसेंस चलेंगे। थोड़ी रह गई आप।
3600, we have excellent agreement. And so that's another step forward for us in being able to, if you're a larger lab with a larger demand, hopefully we'll have the ability now to put that onto an automated platform. And if your needs are smaller, we have a tabletop with the Astute 140 meter. And so when we look at the role of biomarkers and outcomes of AKI, they can provide very important diagnostic and prognostic information beginning at the point of risk assessment. And now for the first time, we actually have actionable information for people like Dr. Kashani, who can make decisions about the level of care that that patient needs. And do we need to better assess whether this patient needs to be taken off particular types of drugs that are nephrotoxic? Do we need to lower the dosage of these drugs? Do we need to do imaging techniques that have contrast? Can we better resuscitate this patient with fluids? So we really are providing an opportunity for having actionable information for the first time and being able to identify AKI events within 12 hours of sample collection. We know that I've shown you that these are novel biomarkers, but they do outperform for risk assessment existing tests that are out there. And that we must have a clear understanding of exactly what information these biomarkers can provide and how they can impact clinical care. And I think this is certainly the role.
ये जो इस स्लाइड में उसने बताया कि आप सैंपल कलेक्शन के 12 आवर्स के अंदर AKI हो सकती है। अगर 0.3 से ज्यादा आ जाए उसको, तो हम ये इंफॉर्मेशन देंगे कि टेस्ट की रिपोर्ट के नहीं, सैंपल कलेक्शन के 12 आवर्स के अंदर AKI हो सकती है, ठीक है। अब वो क्या करे कैलकुलेशन, आपने तो कह दिया जी AKI हो सकती है, इसको उसको क्या फायदा होगा इसका, कोई इसका यूजफुल है। अब उसमें 2-3 सिचुएशन बताई हैं आपको कि अगर आप नेफ्रोटॉक्सिक ड्रग दे रहे हैं उसको होल्ड कर लें, अगर आपका इरादा है कोई कंट्रास्ट मीडिया पे जाके इसको कुछ इमेजिन करनी है, वो ना करें आप बिल्कुल। अच्छा, नंबर 3 है कि आप उसको फ्लूइड दें, फ्लूइड बहुत ज्यादा दें, ठीक है। तो ये इसका मकसद है, इसका फायदा होगा करने का।
Expanding our menu and providing these tests for the clinician. And so what I'd like to say is that we can add value in the
ये value
laboratory
आ गई
by
value.
adding a laboratory test with the goal to improve patient outcomes while reducing the cost of the episode of that care. And so what that means is that the laboratory today can spend a bit more money, but we can contribute to millions of dollars in cost savings or cost avoidance. And so the value of this information is unquestionable. We can save lives, we can save dollars. And let's use the AKI risk score as an example. If this test costs $70, which may seem like a very high number to a laboratorian when we're used to doing glucose and BUN for less than a dime, it may be staggering to us. But AKI can be predicted before we have changes in our serum creatinine, which is a non-sensitive test, it's not sensitive, and we have non-specific tests in the urinary output. And these tests of serum creatinine is a late marker, it's not an early marker. We want something when it's reversible before we have irreversible damage. And it allows us to monitor that patient more closely when we know that that event is impending. So it actually helps us to implement an appropriate strategy for prevention and for support of that patient. And hopefully we can prevent progression to irreversible kidney damage and death. And so in trying to make that financial case with the clinical impact of these new biomarkers, what I was able to do is to take the statistics that I've shared with you tonight regarding the scope of AKI, and look at how much it costs. And what I've done is take the number of patients that were in our ICU and CCU for 2014, multiply the number of total patients in that unit by 3.5%, because that is the admission number of 3.5% of patients will develop AKI. I took 3.5% of those patients in the ICU in 2014, and I looked at what the cost would be based upon the cost of testing shown here on the right in the blue box. $70 a test for those patients, 3.5% of those total admissions to ICU, I would spend $120,000 in the laboratory to provide that testing to the clinician. But if I take the number of patients that we have in ICU and multiply that out with the possibility of having AKI, and that the excess cost of AKI in a patient is $7,500 at the minimum, and I multiply that out by the number of patients, it comes to over $4.5 million. So the cost of performing the test versus the cost of not performing the test, or what the cost of medically incurred AKI is, the difference between those two actually leads to a savings or cost avoidance of over $4 million. And I think that speaks to the C-suite and to the CFO and to others when you're trying to make that financial case about balancing the healthcare cost in the laboratory with the cost of how much it is to treat AKI in your patient population. And we know that AKI has been under-recognized, under-treated, and I think as laboratorians, we have been sort of unaware of this as a important clinical manifestation of abrupt kidney decrease in function. And so there is an opportunity for us to do something here, to come forward by increasing the clinical effectiveness by showing what these markers can do in risk assessment. And so I'd like to leave and say, I think it's us as laboratorians that we have the opportunity to impact care. And how can we do that? By hopefully implementing markers that do have value in risk assessment for patient function of kidneys. So with that, I'd like to thank you very much for your attention.
Okay, we have a few minutes. So any question, please? जिन लोगों को हम दे नहीं सके rights, I'm sorry for that, recording rights, because हम representation शुरू कर दें. खासतौर पर जब वीडियो क्लिप शुरू हो जाती है तो फिर मेरे पास वो ऑप्शन नहीं आती ऊपर कि मैं आपको राइट दे सकूं, तो फिर आपको एक दूसरे से लेने पड़ेंगे. बहरहाल अगर आप मैनेज कर सकें पिंडी में आके तो मेरे पास तो है, इसकी रिकॉर्डिंग है और आपके लिए अवेलेबल। तो एनी क्वेश्चन? माशाल्लाह 20 पार्टिसिपेंट्स हो गए थे, 21 भी हो गए थे। ये क्या चैट में लिखा हुआ लोगों ने? हाँ ठीक है, कोई क्वेश्चन तो नहीं है किसी का? हाँ जी बिल्कुल, एवरी पेशेंट, बिल्कुल बिल्कुल, ये बड़ा अच्छा क्वेश्चन है। ये ज़ियाउद्दीन से है, वेरी गुड। ये क्वेश्चन ये है कि आप किन पेशेंट को आप स्क्रीन करेंगे। तो ये जो आज की प्रेजेंटेशन है वो तो ये हमें बताती है कि हर पेशेंट जो सीसीयू में दाखिल है, आईटीसी में दाखिल है, वो और क्रिटिकली इल है, चाहे उसको कार्डिक इवेंट है, चाहे सर्जरी भी है, चाहे सेप्सिस है, तो आप उसमें करके देखें ताकि आप उसको अर्ली प्रोडिक्ट कर सकें। ये जो इसकी इंटेलिजेंस देखें जरा इस लेबोरेट्रिशियन की खातून की, कि उसने डाटा ये कटा। अब $70 का मतलब है 7,000 रुपीज बनते हैं, 7,000 का एक टेस्ट होगा, ठीक है। अब 7,000 का अगर एक टेस्ट हो तो आप हमारे तो बिल्कुल ही कोई नहीं, वो तो हमें पकड़ के मारेंगे कि 7,000 का एक टेस्ट आप कर रहे हो। लेकिन उसके मुकाबले में आप कॉस्ट देखें कि अगर आपने अर्ली डिटेक्ट नहीं किया तो उसकी जो डायलिसिस, वो जो उसने 3.5% इंसिडेंस को, यानी जितने पेशेंट दाखिल हुए हैं टोटल, उनका 3.5% निकाला कि उनको AKI हो जाएगी, और एक AKI की जो डायलिसिस कॉस्ट है वो निकाली। अब वो उससे वो इतने मिलियन रुपीस बन गए, 5.7 मिलियन, ठीक है। और जो लेबोरेटरी का खर्चा था वो $1,20,000 था सिर्फ, ठीक है। तो वो बहुत अच्छा उसने अपना केस फीड किया कि 4 मिलियन की आपकी सेविंग है। और सॉरी, और वो ये भी कहती है कि ये आपको डाटा आपके पास होना चाहिए, क्योंकि जब आप एडमिनिस्ट्रेटर के पास जाएंगे उनके भी वही मसले होंगे जो हमारे हैं, कि जब आप हाई अथॉरिटीज को जाके कहेंगे कि मैंने SCR टेस्ट शुरू करना है जिसका एक टेस्ट 7,000 का, तो वो कहेंगे ये क्या बात है। फिर जब आप एक्चुअल डाटा देंगे उनको तो दे विल हैव टू डू इट। तो ये भी एक है कि कैसे आप जो है ना इसको अपने केस को प्लीड करते हैं, आपका डाटा होना चाहिए स्ट्रॉन्ग, ठीक है। तो अगर कोई और क्वेश्चन नहीं है तो हम इसको क्लोज करें, 10 भी बज गए। देन सब लोगों ने एंजॉय किया, ओके ठीक है। पहले कोई क्वेश्चन हुआ तो मुझे पूछ लीजिएगा, ग्रुप में लिख दीजिएगा। हाँ हाँ बिल्कुल बिल्कुल, वन टाइम टेस्टिंग, बिल्कुल 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 सही है। लेकिन अगर नेगेटिव आ जाए और पेशेंट की कंडीशन डिटोरेट कर जाए तो फिर आप दोबारा भी कर सकते हैं, ठीक है। तो लेकिन ये नहीं है, उसको आप प्रोग्रेस के लिए मेरा ख्याल है इसको नहीं अभी इतना यूज कर सकते, सीरियल नहीं कर सकते। थैंक यू वेरी मच जी, बहुत। आई एम क्लोजिंग नाउ।